Where is Aiman?
Waalaikumsalam.
Waalaikumsalam.
Okay. Ashraf ya. Aiman ada mana Aiman? Oh ini Aiman, okay. Alright ya. Masih ramai lagi yang tak join. How many of you? 36 kan ya? Masih tak. Lagi 8 orang. Ke 7 orang. Tak apalah. So appreciate whom join early on time. Yang tepat waktu tu. Okay, so let's have kitab Al-Fatihah. Alhamdulillah. Rabbi syrah li sadri wa yassir li amri. Alright ya. Now seminar kardio kan ya. Itulah saya. Sorry ya, saya tak sempat siapa je ni. Suhaib ya. Suhaib ada?
Ada.
And then Aiman. And then Akmal ya.
Ada doktor.
Akmal mana? Hello?
Hello. Ada doktor.
Akmal ada?
Ada doktor.
Ada ya? Cannot hear you clearly. Oh ini ada. Okay, alright. Apologies I haven't review your slides lah. Tak apa, we just go through and then nanti we discuss ya. Siapa present dulu? Suhaib dulu. Alright. You may start lah. Mana? Suhaib. Okay. Alright. Sorry ya, before start, I brief you few rules lah. First rule, this is because this is seminar meeting session. You need to open your video, unless kalau memang truly poor connection lah. So please open your video. Kalau you don't open your video, not necessarily you are there kan. You boleh je hilang ke mana. Okay. And then hopefully a free presenter tu not more than 30 minutes lah. Maybe 15 minutes if you have only 20-30 slides itu okay. And then we go for discussion ya. Alright. Alright, Suhaib boleh start?
Okay. Can you all see the slide?
Yes.
Yes, Suhaib.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Suhaib Muhammad Abdul, matric number 1813507. So today we'll be discussing about some cardiology, and I will be presenting about the overview of the valvular heart disease. The next presenter, Aiman, will be presenting about infective endocarditis, and Akmal, the presenter after that, will be presenting about the heart failure in childhood. So these are my outline. So the first one, we have the anatomy of the heart. Next is the introduction of the valvular heart disease. For the third one is we have the difference of stenosis versus regurgitation. The fourth are the etiologies. The fifth is the pathophysiologies, and sixth is the others, where I combine signs, symptoms, investigation, treatment into a table, so it will be easy to differentiate or to see. So first of all, we have the anatomy of the heart. So let's recap about some anatomy of the heart. So as you know, the heart is a muscle that contains 4 chambers. That is the right atrium, right ventricle, left atrium, and left ventricle. So So the function of the heart is to pump blood of the the left side of the heart will pump blood pump blood to the rest of the body, while the right side of the heart right side will pump blood to the pulmonary circulation. So between these heart chambers, we have a valve of that is and there is four valve. So this one here we have the tricuspid valve, which consists of three cusps, and then after that here we have the pulmonary valve. On the left side we have the mitral valve or the bicuspid valve, and the next to it is the aortic valve. So for, as you all know, the normal sinus rhythm consists of the sound of the lub dub. So the lub is when there is the closure of the tricuspid valve and the mitral valve. So when those two valves closes, these two valve here closes, it will make the lub sound. So this happens at the beginning of the systole. While for the second heart sound, which is the dub in the lub dub, is due to the closure of the aortic valve and the pulmonary valve. So, and this occur at the beginning, end of the systole or beginning of the diastole. So as you all can see, this is the picture of the valve, and the mitral valve is the only valve that has two cusps, while the rest have three cusps. So okay, moving on. So some introduction. So a valvular heart disease is characterized by the damage or a defect in one of the heart valve, which are, like I mentioned earlier, the mitral valve, the aortic valve, the tricuspid valve, or the pulmonary valve. So the mitral valve controls the blood from the left atrium to the left ventricle, while the aortic valve controls blood from the left ventricle and is go to the systemic circulation so that it can supply the whole body. So the most common problem is the acquired left-sided valvular lesion. So in this in my seminar, I will only concerning about the mitral valve and the aortic valve, which are the valve that is located on the left side. So when there is when these valves are abnormal or have a defect, they can produce a turbulence flow, where you can hear this as a murmur during auscultation. So so the prevalence for the valvular heart disease is estimated at 2.5% in the population of the US, and it sharply increases after the age of 75 by 13%. And aortic stenosis is the most common degenerative valvular lesion. Moving on to the stenosis versus regurgitation. So these are, try to compare it, stenosis versus regurgitation. So what does stenosis mean? Stenosis it means when the valve does not open properly. So as you can see in this picture, it's not opening this is the normal opening of the valve, while this is stenosis where it opens, it does not open properly. So it's like partially open. So this, what will happen is it will impede the normal blood flow, and due to this, it will narrow the flow of the blood. So when the valve is narrowed, the heart has to pump harder to compensate that narrowness. So the heart have to compensate by pumping even harder to allow more blood to enter to the next chamber. So and then the heart need to pump harder so that the blood can be pumped through the whole body. So when this happens, it can build up pressure and can strain the heart and also reduce the blood flow towards the body. That's for stenosis. While for regurgitation, it means that the valve does not close properly. So the counterpart, so stenosis is when the valve does not open properly, while the regurgitation is when the valve does not close properly. So when regurgitation happens, there will be a backflow of blood. So the blood will move backward through the valve. So the heart also needs to work harder and make up for this leaky valve. So due to this leakiness, there will be increase in the volume and also increase in the pressure of that chamber. Next, we're moving on to some etiologies. So these are focused on the left side only because we're only focusing on the mitral and the aortic. As you can see, some of the etiologies or the causes of the mitral stenosis is the rheumatic fever and congenital causes. While for the mitral regurgitation, there are a lot more, that can be subdivided into acute and chronic. So some acute causes are endocarditis, trauma, or papillary muscle rupture, or rupture of the cordia muscle. While for the chronic, it could be due to rheumatic fever, a healed endocarditis, or a mitral annular calcification. So, and then we move on to the aortic stenosis, where we have the congenital aortic stenosis. Some of the causes are congenital, where the valve is actually bicuspid or unicuspid. As you all know, the aortic valve is actually tricuspid, but in congenital, if a person have a congenital problem of the aortic valve, they can have a bicuspid valve or a unicuspid valve for their aortic valve. And there's also a degenerative calcification, and can also be due to rheumatic fever. Next, for the aortic regurgitation, there's also a lot more causes that can lead to aortic regurgitation, and some are also congenital, like bicuspid, like the aortic stenosis. Some can be due to endocarditis, rheumatic fever, and trauma, and some other disease. And the for the root disease, they can be due to Marfan syndrome or bicuspid valve, and also aortitis and hypertension. For the fifth one, we move on to the pathophysiology. Oops. Okay, so I'll explain a little bit about some of the pathophysiology. First of all, we have the mitral stenosis. So when mitral stenosis occur, so this will lead to an increase in the left arterial pressure. So when left arterial pressure increase, the sum of the transudation of the fluid that in the pulmonary circulation will it will be like static there. It's not going to move efficiently, so there will be transudate, and this can lead to dyspnea at rest. And also when that occurs, this can lead to a pulmonary venous hypertension. The pulmonary veins, that it can lead to the pulmonary venous hypertension. And then when pulmonary venous hypertension occur, since it is in the the pulmonary circulation, if you backtrack to that, if you can see, this is the pulmonary vein. So this connects to the lung, and then we have the lung, and then the lung will be connected to the pulmonary artery. So when you have the pulmonary venous hypertension, you can also have the pulmonary arterial hypertension. So when when pulmonary hypertension occur, this will lead this can cause right ventricular hypertrophy, because the right side of the heart need to pump harder, so that to inject blood out of the lung and out of the heart into the pulmonary circulation. So this hypertrophy is a compensatory mechanism, and also the right ventricle also can dilate, because they have to compensate by increasing the volume of blood to stay in the right ventricle. So so when there's right ventricular dilatation occur, it can also lead to tricuspid regurgitation and tricuspid valve ring dilatation. So when tricuspid regurgitation, so when there's right ventricular dilatation and tricuspid regurgitation, this can lead to elevated JVP, liver congestion, ascites, and also fetal edema. And for when the right ventricular dilatation occur, this can finally lead to the right ventricular failure. So for the mitral regurgitation, so as you all know, mitral regurgitation, there is the blood leaks backward when the heart is contract. So there is less blood that is pumped out of the heart and to the body. So part of the left ventricle regurgitate into the left atrium during systole. So left arterial blood volume increases, and the left and the size, the arterial size also increases. You know, it will increase so to pump more blood into the left ventricle. So that's why it's increased. So so the volume of blood returning from the left atrium to the left ventricle also increases, because you know when there's leaky, there will be a stagnant amount of blood in the previous chamber, in this case in the left atrium. So when the next pump contraction occur, there will be more blood that goes from the left atrium to the left ventricle. So there's going to be diastolic overfilling of the left ventricle. So the left ventricle will be overfilled, and the left ventricle will be hypertrophy, and dilatation will occur. So this is because as a compensatory as well, since there is a larger amount of blood that is filling the left ventricle, the left ventricle has to pump more harder, so that it can, so that the blood can travel towards the whole body. So this hypertrophy will occur, and also dilatation will occur due to, they have to compensate for the sheer amount of volume of blood that enters from atria to the ventricle. And finally, this will lead to left ventricular failure, which later on can also lead to pulmonary hypertension. And finally, this too can lead to right ventricular failure. So at the end of the mitral and aortic stenosis, both can lead to right ventricular failure. So we move on to the aortic stenosis and aortic regurgitation. So in aortic stenosis, there is left ventricular outflow or obstruction. So when there's a left ventricular outflow obstruction, this will lead to an increase in the left ventricular systolic pressure. When there's obstruction, or when there's the opening is small, so there will be increase in pressure. So the left ventricular pressure will increase. That will also lead to left ventricular hypertrophy. So because the heart always need to pump even more harder, and this can left ventricular hypertrophy can lead to left ventricular dysfunction, or it can lead to myocardial ischemia, because when there's hypertrophy, there will be an increasing amount of oxygen demand, and if the amount of blood that is flow cannot compensate that oxygen increasing in oxygen demand, that can finally lead to left ventricular failure. And then for the aortic regurgitation, when aortic regurgitation happen, there is an incomplete closure due to like infective endocarditis or trauma, or the bicuspid valve. So this can lead to aortic regurgitation. So in aortic regurgitation, the diastolic reflux, there's the diastolic reflux that flow through the aortic valve. So there will be an increase in the left ventricular volume. So as the same here, so when the volume increases, there will also increase in the left ventricular pressure. So the left ventricle, when there's increase in the left ventricular volume, there will be the left ventricle will be overloaded by the sheer amount of blood. So there will be increase in the volume during diastole. Here. So there will also be increase in the left ventricular mass that can lead to myocardial ischemia, or it can lead to left ventricular dysfunction. So as the left ventricle increases in mass or hypertrophy, it will increase in the oxygen demand. When there's increase in oxygen demand, but the heart cannot compensate that or cannot cope with the increasing demand, that can lead to left ventricular failure. Okay, so finally we're moving on to the others. So, like I said, I have compiled into a table for some of the definition, the causes, sign and symptom, investigation, and treatment management, prognosis, and complication. So let's go one by one. So for the mitral stenosis, so the definition I said earlier is there is obstruction of the left ventricular inflow at the mitral valve. And for the aortic mitral regurgitation, there's a backflow. So this is due to incomplete opening and incomplete closure of the mitral valve. So for the aortic stenosis, this also can be obstruction of the blood flow across the aortic valve. And for the aortic regurgitation, there's a diastolic flow of blood from the aorta to left ventricle. So this is incomplete opening of the aortic valve and the incomplete closure of the aortic valve. So the causes I already mentioned some earlier, like for the mitral stenosis, we have rheumatic fever, congenital or prosthetic valve. Mitral regurgitation, we have infective endocarditis, rheumatic fever, and also mitral valve prolapse. For the aortic stenosis, it could be due to congenital, like I said, bicuspid or even or unicuspid valve, a rheumatic heart disease, and calcification of a normal aortic valve. And finally, for the aortic regurgitation, it can be due to infective endocarditis, congenital, and also rheumatic fever. So these, moving on to the sign and symptoms. So these are some of the sign and symptoms for the stenosis and regurgitation. As you can see, most of them is like nearly the same. There is some difference. So for the mitral stenosis, we have dyspnea, hemoptysis, post-nocturnal dyspnea, exertional chest pain, syncope, and also pulmonary hypertension. And for the mitral regurgitation, there's also dyspnea, there's fatigue, there's pulmonary edema, there's also lethargy, tachypnea, palpitation, and pansystolic murmur. At the end, I will show some of the murmur. So, and then for the aortic stenosis, there's exertional angina or chest pain. There's exertional syncope, heart failure, dyspnea, and also systolic ejection murmur. And for the finally for the aortic regurgitation, there's also dyspnea. So like the same, there's orthopnea. There's also PND. There's fatigue. There's exertional angina, and finally there's water hammer pulse, or the other name is the collapsing pulse. So for investigation of these stenosis and regurgitation, we commonly do a chest X-ray and check the ECG and also echocardiogram. So for the mitral stenosis, when we do chest X-ray, we can find the enlargement of the left atria, and we can also see some pulmonary venous hypertension and also a calcified mitral valve. And when we check for the ECG, we can see some atrial fibrillation. So for the for mitral regurgitation, enlargement of the left atrium, there will be enlargement of left atrium, left ventricle, or even both chamber. And on echocardiogram, we do this to assess the size of the chamber of the heart and the movement of the valve, and also the motion of the heart wall. And then for the aortic stenosis, we do chest X-ray to see the heart size, and then to see if there's the prominence of the ascending aorta. And the ECG in ECG examination in ECG we can see there is a left ventricular hypertrophy. And for the echocardiogram is to check the gradient, the structure, and also the pressure gradient within the chambers. And finally, for the aortic regurgitation, there is the for a chest X-ray, it can indicate the enlarged heart and the dilated ascending aorta. And in ECG examination, we can also see left ventricular hypertrophy. Okay, so for the treatment and management, most of these they have divided into medical and surgeries. In medical, we just give medication, and in surgery, you do surgery. So in mitral stenosis, mild mitral stenosis does not often need treatment. But for if you need treatment, if you need for medical treatment, you just treat the some of the signs and symptoms, like you give digoxin in atrial fibrillation and diuretic in heart failure. And for surgery, you do a percutaneous balloon valvotomy or a valve replacement to relieve the symptoms. And for the mitral regurgitation, you also you can give diuretics to improve the symptoms, and also anticoagulant to prevent blood clotting. And for surgery, you can also do a replacement of the valve before the left ventricle become impaired, and also you can refer to the surgery, if the symptoms worsen. For aortic stenosis, same as before, you can also use digoxin, diuretics, ACE inhibitor, or ARB for patients that are not suitable for surgery. And for those who can opt for surgery, they can do an aortic valve replacement, a balloon valvuloplasty, and also transcatheter aortic valve implantation. And finally, for the aortic regurgitation, for medical, you can also use diuretic, vasodilators, and ACE inhibitor in order to treat and relieve some of the symptoms. And for surgery, you can also use aortic valve replacement. For the prognosis, most of these, aortic stenosis, mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation, they generally have a good prognosis because, with surgery, they have a better prognosis than before. And finally, we have the complication. So the first one is for the mitral stenosis. The complication for mitral stenosis is pulmonary hypertension, pulmonary edema, infective endocarditis, and atrial fibrillation. While for the mitral regurgitation, you also have atrial fibrillation. There's a dilated heart. It can also lead to heart failure and pulmonary artery hypertension. For the aortic stenosis, the complications are the sudden cardiac death, heart failure, calcific embolism, and also conduction defect. While for the aortic regurgitation, some of the complication is heart failure and sudden cardiac death. So this is a cartoon for aortic. I can only find for the aortic stenosis. I wasn't able to find for the mitral stenosis, mitral regurgitation, and the aortic regurgitation. So I hope this will do. So to summarize a bit, so the aortic stenosis, there will be a narrowing or a calcification of the aortic valve that can lead to ventricular outflow obstruction. So the signs and symptoms can be possible heart failure, angina, and also syncope. So the causes can be due to calcific disease of the trileaflet valve, the aortic valve, also calcification of the valve, and also due to rheumatic valve disease. And some treatment and management is you can do aortic valve replacement. These are my reference. So before I end my presentation, I would like to show some of the, like I said, the presentation, in mitral regurgitation, there's a pansystolic murmur, and there's in aortic stenosis, there's the systolic ejection murmur. I would like to show you a video for, to differentiate these types of findings. Okay, can you all see? Hello,
Yes.
can you all see? Okay.
Yep.
Yeah, we can see.
So for this, I recommend you all to put on your headphones because you get a better understanding or better listening experience, so that you can differentiate it easily. So please put on your headphones. So first and foremost, to know the abnormal, you have to know the normal. So I will play for the normal heart sounds. Can you all hear? Okay. So you guys were able to hear that, right? Just making sure. Hello.
Yes, yes,
Yeah,
clear.
Okay.
kinda.
So, those that was the the normal heart sound. So next we move on to the mitral stenosis heart sound. Okay. So moving on to the holosystolic murmur, or also the pansystolic murmur in the mitral regurgitation. Next for the aortic stenosis. And finally, for the aortic regurgitation. Okay, so that's all. Don't worry if that wasn't clear. I will send the link later on. So that is all for my presentation.
Right, thank you, Suhaib. Quite informative ya, your slide presentation, especially the sounds tadi ya, the murmur. So you can learn more ya after this. Nanti minta the file to Suhaib. Actually you can download by yourself juga. You get from internet kan juga. Alright. And yang slide tadi yang again yang important part ya actually the tables tadi ya. Slide berapa tadi? 16, 17 and few other slide tadi. Boleh ini lagi, you share lagi the slides.
Aja. This one?
Okay, 16, 17 rasanya. Okay. Ada few tadi pasal etiologi ya. If I may summarize, the causes of heart disease kan you just simply classify whether it is congenital or acquired kan. Alright.
Yes.
For valvular heart disease, both can be a cause, but more common will be acquired, and then the most common will be rheumatic heart disease as complication from rheumatic fever. So rheumatic fever too can develop carditis, and then as part of the complication develop valvular heart disease, especially the left side mitral and aortic. Usually yang rheumatic heart disease itu the more common will be regurgitation ya. Kalau stenosis jarang sikit ya. And then less common yang acquired tadi endocarditis ya. Endocarditis as part of the infection of the endocard to the valve, dia boleh jadi stenosis, boleh jadi regurgitation. And then congenital is also possible ya, even though rare, tapi usually congenital itu possible, and then since birth ya. Nanti the one that you need to understand, nanti ada topik rheumatic fever kan, so you need to understand that rheumatic fever most common incidence usually at school age ya, 5 to 12 year old tuh. 5 or 7, youngest will be 5 year old ya. So there is no rheumatic heart disease in children less than 5 year old ya. So kalau umur dia less than 5 year old ada valvular heart disease ya, it is congenital lah, usually since birth. Okay, kalau more than 5 years old possibly it is rheumatic heart disease ya, from rheumatic fever. Okay, so yang more basic about the location of the valve you must know kan, dah ada lecture masa year 2 kan yang itu ya. Yang itu you kena tahu your basic knowledge, you must know the location of the valve, ada 4 tu, where S1 and S2 tadi, so have dah buat introduction tadi. And then yang you need to know now is you need to understand the stenosis or regurgitation ya. Stenosis is rigid ya, so dia hard to open, difficult to open. And then regurgitation is insufficiency ya, difficult to close, bukan difficult actually, unable to close properly. So itu beza ya, can affect all valves ya. So mana-mana. And then balik table slide 16 and 17 tu. Okay. Yang sign and symptom tu, 16 dulu. Alright. Stenosis, the sound will be similar ya. Only a matter of location kan. Mitral is on the apex, aortic tu ya on the upper right ya, sternal edge ya. Kalau stenosis you will get similar sound ya, systolic ejection murmur. Sorry. Masa aortic, stenosis, systolic ejection. Kalau mitral stenosis will be on diastolic murmur. Ya. Okay. And then yang regurgitation, the mitral will be on pansystolic, and then aortic regurg will be early diastolic murmur. Timing tu maybe you difficult to understand now, tapi just slowly imagine the hemodynamic, the blood flows. Ya. When it is systolic phase after S1, when there is ejection of the ventricle, so if there is aortic stenosis, you can hear a systolic ejection murmur. Ya. Atau in same systolic period timing, if there is mitral regurgitation. Ya. So aortic stenosis dengan mitral regurgitation timing dia sama ya, systolic. Tapi location pasti lain kan. Kalau aortic stenosis on aortic valve, and then usually ejection dia early ejection ya. Kalau regurgitation dia usually pan systolic atau hollow systolic ya. Location on the mitral or apex. Tapi masa dia diastolic, after closure of the aortic valve and pulmonary valve, you akan jumpa early diastolic murmur kalau on aortic regurg, atau kalau on apex you also get mitral stenosis on diastolic murmur juga, usually end diastolic. Tuh ya, how do you recognize the murmur? Tadi sound tadi very clear tadi, the example the files tadi. Investigation sama lah, actually no need to differentiate in four rows nih atau 4 column. Jadi satu je sama investigation ya, semua pun kita buat X-ray, ECG, and echo. Okay, yang 17. Okay, treatment pun sama ya, medical treatment usually to treat the heart failure ya. As part of the complication, most common will develop heart failure. If stenosis, the problem will be hypertrophy ventricles kan. After hypertrophy dia akan failure. Kalau regurgitation will be dilatation karena enlarged ventricles dilated, lama-lama dia heart failure. So kalau develop heart failure, we give anti-failure treatment ya. Ada 3Ds, senang je 3D ya. Usually first D is diuretics, second D is dilator, third D is digoxin ya. Usually we start from diuretic dulu, kalau no improve tambah lagi with vasodilator, captopril. Kalau tak improve juga, if poor ejection, poor systolic ejection fraction dia, kita pakai digoxin. So sama je, sama-sama in every valvular heart problem sama semua ya treatment kalau heart failure, yang medical treatment. And then surgical treatment lain sikit. Yang stenosis, when there is a rigid heart to open, we can try to do ballooning valvuloplasty dulu. Try to open dengan balloon. We inflate a balloon on the valve dia supaya rigidity itu dia kurang sikit ya, supaya dia lembik sikit boleh open. Tapi kalau regurgitation, if need surgery ya we replace. Yang stenosis tadi kalau fail with ballooning ya we replace juga. Tapi usually we try to open with ballooning dulu, valvuloplasty. Prognosis ya depend on the complication, severity, semua sama. Complication pun sama ya. Pasal semua kan usually heart failure FLL pun later boleh develop pulmonary hypertension yang angina or infarct tu usually on the left heart. Kalau inadequate coronary artery circulation, dia akan develop angina lah, develop infarct, heart attack sama juga kalau syncopal attack, the pathophysiology is inadequate cranial punya blood flows, intracranial blood flow. Kalau tak cukup ya dia syncope lah patient. The problem dia kalau on the left heart lah, on the mitral or aortic. Yang pulmonary dengan tricuspid, nanti belajar sendiri, usually pun lebih kurang sama. Tricuspid is equal to mitral, tapi location lain lah. And then pulmonary pun equal to aortic. Okay, so simple. Nanti you belajar slow-slow, masih tak paham kan? Kau dah paham semua? Kalau dah paham, okey lah. Boleh jadi cardiology semua ni. Alright. Questions? Kalau Gmeet ni saya tak boleh nampak yang tak buka video ni tak nampak. Yang ternampak yang ada open video je. Kalau Zoom kan tahu yang tak ada video. Ke yang nama je ni. Ni Najimi Rosli ni tak ada video. Oh ada, boleh. Tak ada yang tanya ke ni? Okay. Dah, alright. If no question, okay lah. So, ni ada seorang yang tak attend ya. Sama ke siapa tu? Bukan Lutfil kan? Yang year 3 ni saya pun tak hafal nama. Siapa yang absent? Tak tahu. Tak apalah, nanti PA nanti Farah will list down lah, will check siapa yang tak attend. Okay, next question. Alright. Proceed lah. Second presentation apa? Aiman.
Yes, Aiman. He'll be presenting about infective endocarditis.
Alright.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
My name is Aiman Fidaus, and today I will give a seminar about infective endocarditis. This is my outline for my seminar. The definition. According to Pediatric Protocol for Addiction, infective endocarditis is defined as infection of endocardial surface of the heart, which is the innermost surface, and it frequently involves the heart valve. This is associated with high mortality and severe complication. That's why early treatment and detection is very important. The epidemiology. In developed countries such as Japan or America, infective endocarditis mostly affected people around 50 to 60 years old, whereby in developing countries such as Malaysia, it mainly affects 20 to 40 years old. For gender, male is more prone to have infective endocarditis compared to women, which ratio 2 to 1 or more than 2 to 1. The microorganism that most common is Streptococcus species. And for the side, left-sided heart valve are most commonly affected. compared to right side of the heart. And for the causes, rheumatic heart disease is still the most common issue in developing countries, so it remains generally the most common uh, causes of infective endocarditis in developing countries. But about 50% of infective carditis patients doesn't have predisposed history of valve disease, and that's a complication rates is about 16 to 33%, which is worrisome, and mortality rates is up to 39%. But surgery has shown to reduce mortality in some of these complicated cases and have proven to be required in about 50% of the patient. Now let's focus on Malaysia. There was a study in Hospital Kuala Lumpur on 2013 to 2014. It is reported that in the study, 36 cases happened in 2 years, where male to female ratio is 4 to 1 and median age is 36 years old. Malay is most commonly affected compared to other races, but take note that from the study, IV drug use is the most common predominant factor compared to rheumatic heart disease or even congenital heart disease. Almost half of them need surgery intervention, and the most common organism is methicillin sensitive Staphylococcus aureus. Epidemiology, effective endocarditis in congenital heart disease. A population-based review of the Quebec CHD database from 1988 to 2010 reported that cumulative incidence of effective endocarditis was about 6.1 per 1,000 children, whereby the mean age of IE in children is about 8 years old. And the most common etiological agent is gram-positive cocci, such as Staphylococcus. And overall inpatient mortality for children is about 9.5 to 11%, and for adult is 6 to 7.2%. Classification. Adapted from European Society of Cardiology, effective endocarditis guideline. Effective endocarditis can be classified into, the first one is localization, whether it is left-sided native effective endocarditis or left-sided prosthetic valve endocarditis, or right-sided native valve effective endocarditis, or device-related effective endocarditis such as central catheter. And the second classification is based on mode of acquisition. The first one is whether the patient get the effective endocarditis from healthcare associated, and it's subdivided into two, nosocomial and non-nosocomial. Nosocomial is when the patient exhibit sign and symptom of IE after 48 hours of admission to the ward, and non-nosocomial if this patient exhibit the sign and symptom less than 48 hours. And the second mode is in IV drug abuse, and the third mode is community acquired. The third classification is based on recurrence, whereby the patient have relapse or reinfection. The difference between relapse and reinfection is relapse is having the same episode, having infective endocarditis back after has been cured, which the same microorganism less than 6 months. Whereby reinfection, if the patient have repeat episode but different organism, or have repeat episode which the same organism but more than 6 months after the first infection. And take note that active infective endocarditis is how we want to know that this patient have active infective endocarditis. The first one is whether it's persistent fever and positive blood culture. Second one is inflammatory morphology findings during surgery. And the third one is the patient on antimicrobial therapy. And the fourth one is evidence of active infection on histopathology. This is the example of histopathology. As you can see that there is colony of Staphylococcus. And this is bioprosthetic valve, and that is the colony of Staphylococcus. The etiology. I have summarized the etiology in 3 columns: bacteria, fungi, and others, and I have sorted it from the most common to the least common. As you can see, that the most common is Streptococcus viridis and followed by Staphylococcus aureus. Streptococcus viridis is the most common bacteria flora of our upper respiratory tract. But take note that fungi infection of infective endocarditis often result to more complicated problem compared to bacterial infection of infective endocarditis. Risk factor: skin skin breaches, renal failure, immunosuppression, such as diabetes mellitus, for example, IV drug users. All of these are risk factor for having bacteremia or infection or general infection. And then we have congenital heart lesion, and congenital heart lesion will be explained by Akmal after this. And prosthetic cardiac valve, materials for treatment, and after surgical procedure of any heart lesion. And rheumatic heart disease, as I said before, one of the most common factor of infective endocarditis, and also device related such as central vascular catheter, also risk factor for having infective endocarditis. The pathophysiology. The pathophysiology is simple. The first step is when there is a turbulent blood flow, maybe because of aortic regurgitation or aortic stenosis, for example. And this turbulent the blood flow will traumatize the vascular endothelium of the heart. The vascular endothelium, when it traumatized, it will injury. The injury of this endothelium will initiate immunological response that will create fibrin and platelet deposition. And this deposition will form what we call non-bacterial thrombotic embolus, which is NBTE. And for prosthetic valve, so for prosthetic valve or device related, there will be biofilm on that device that will serve as adhesive substrate for infection. Just imagine it like a glue to the microorganism. And then when there is bacteremia in the blood, it will colonize this NBTE and the biofilm, and it will proliferate at that site. Some bacteria have surface proteins such as FIM-A antigen that may may help in proliferation, adhesion factors, and some may help in evading immunological response. This is the final result, which is the vegetation. Clinical manifestation. The symptom of infective endocarditis is fever. Fevers, some reported that it is low-grade fever and spike at the afternoon. And malaise, anorexia, weight loss, arthralgia, myalgia, which is pain in the muscle and pain at the joint, chest and abdominal pain, and night sweat. Sign. And sign is stigmata. Take note, stigmata of the infective endocarditis. There are four, which is the splinter hemorrhage, oscillate nodes, genuine lesion, and raw spot. And the other sign is anemia, clubbing, petachy, tachycardia, cardiac murmur is one of the important signs. Splenomegaly is because of infection. Arrhythmia, microscopic hematuria is also one of the important signs of infective endocarditis, besides of the cardiac murmur and stigmata of infective endocarditis. Splinter hemorrhage is red streak under the nail bed, and oscillate nodes is a painful nodes at the tips of the finger of the toes. And genuine lesion is painless subcutaneous node at palm and sole. And raw spot is hemorrhagic spot at the retinal, whereby this stigmata is mainly because of immunological deposition of antigen antibody complex. This is the picture of clubbing. Investigation and diagnosis. How you want to investigate infective endocarditis, and is based on blood investigation, echocardiography, blood culture, and also put other imaging modalities. Blood investigation. When we do full blood count, we could see anemia and leukocytosis, a sign of infection. This also ESR and CRP also elevated, indicate sign of infection. Renal profile will show azotemia, which is high creatinine and high nitrogen. Anti-nuclear positive, anti-ANP and rheumatic factor were positive. When we do liver function test, ALT will slightly increase, and the most important is when we do urine fluid examination, we could see macroscopic hematuria and proteinuria if we do urine dipstick. And the second one is echocardiography. Echocardiogram is two types of echocardiogram. The first one is TTE, transthoracic, and the second one is transesophageal. The finding of echocardiogram will indicate any endocardial or valvular vegetation, or abscess, pseudoaneurysm, new dehiscence of prostatic valve, which is dehiscence is like disattachment of that valve from the annulus, and any fistula and or any valve leaflet perforation. Echocardiography combined with Doppler study could determine that lesion size, shape, location, and mobility of that lesion. And the presence of valve dysfunction can be determined, and its effect on left ventricular performance quantified using echocardiography and Doppler study. Doppler study is simply ultrasound, but it's a special ultrasound that can show blood flow. And second one is helpful. This echocardiography is helpful in predicting embolic compilation as by lesion more than 1 centimeter and fungating masses are most prone to become embolus. And the third one is the absence of vegetation does not exclude endocarditis, because sometimes vegetation can be detected using echocardiography at the late phase, not at the early phase. So what is the difference between TTE and TOE? TTE may show vegetation, but only if it is more than 2 millimeter. And when there is clinical suspicion of infective endocarditis, as the medical doctor suspect especially FIE, we do TTE first. And if the negative, we repeat the TTE. And if it's still negative, but we still suspect this patient FIE, we can do TOE. TOE is more sensitive, but it requires anesthetic for children, so the risk and benefit need to be considered. And TOE is advisable if the infective endocarditis is related to prostatic valve and prostatic cardiac material, and etc. etc. But when we completed antibiotic regimen for 2 to 4 weeks, we recommended to assess using TTE. And then the example of echocardiography is you can see the left picture. The left picture is TTE, then the right picture is TOE. You can see that here is the vegetation of the mitral valve, and here you can see the abscess cavity. And here you could see the anterior, there is some thicken and the mitral leaflet. Other major modalities I put, you can do CT scan, MRI, nuclear imaging, and regular ECG to more assess effective endocarditis. For the blood culture, blood culture is important in diagnosing infective endocarditis. 3 to 5 separate blood collection should be obtained because we want to exclude contamination from normal flora of our skin. 90% of these cases, the causative agent or the etiology can be recovered from the first 2 blood culture. And antimicrobial pre-treatment, which is a type of prophylaxis, will reduce the yield of blood culture to 50 to 60%. Okay, from this type of investigation, we diagnose this effective endocarditis using the modified Duke criteria. There is 2, major and minor. Major, which is blood culture positive for IE or imaging positive for IE. And minor is this 5, which is there any predisposition or any fever or any vascular phenomena such as genuine lesion, any hemorrhagical phenomena such as raw spot, and any microbiological evidence. And from this major and minor, we could assess whether this patient we can diagnose if this patient have effective endocarditis, definite endocarditis, or possible infective endocarditis or rejected infective endocarditis. This table need to be memorized. And for management, The management is mainly antimicrobial therapy. If we suspect this patient have infective endocarditis, firstly we give empirical treatment until the blood culture result is available. When the blood culture result is available, we stop empirical treatment and we start definite treatment according to what that microorganism infect. And this is the empirical treatment. Basically, we give penicillin, which gentamicin. But if this patient allergic to penicillin, we substitute the penicillin with vancomycin. And if this patient have endocarditis related to prostatic valve, we give addition of oral rifampicin. This is tips to remember. And this is a table for definite treatment. This slide is for streptococcus. This is for streptococcus. As you can see here, if allergic, we give vancomycin. And if it is not allergic, we give penicillin. And if this streptococcus is relatively resistant to penicillin, we still give penicillin, but with extra gentamicin. And this is for methicillin susceptible. And as you can see that if it's resistant, we give extra gentamicin. And this is when I say that if it's related to prostatic valve, we give extra rifampicin. In addition to gentamicin and doxycycline or penicillin. And when we need to know that this patient needs surgical intervention, when this patient have heart failure or uncontrolled infection. Uncontrolled infection is when we have finished the antibiotic regimen, but there is still positive blood culture in the blood, positive blood culture. So we need surgical intervention. And then lastly, if we want to prevent embolism, if you assess that the vegetation is very big, like more than 10 millimeter, so surgical is needed. Complication. This is a general complication of infective endocarditis. It will make a heart failure, peripheral disease, pericarditis. If it if the embolus reach the renal, it will cause glomerulonephritis, renal infarction. If the embolus go to the brain, it may cause brain abscess, meningitis, cerebral hemorrhage. Septic arthritis and vertebral osteomyelitis is also one of the clinical symptom of complicated clinical symptom of infective endocarditis. And myocardic aneurysm is the dilatation of vascular, usually happen at the bifurcation. And this is complication due therapy. Sometimes the antibiotic that we give will cause some complication also to the patient, such as ototoxicity, nephrotoxicity, or drug fever, or bleeding, because we give anticoagulant to when we do the therapy. The prognosis of infective endocarditis is often good. The cure rate is as above. More than 90% is in uncomplicated endocarditis caused by Viridian streptococci. And if it involves gram-negative bacilli, a rare organism, is very poor prognosis. And the poorest if it involves fungal endocarditis. And we should cure it about 50% even with the valve replacement, which is a surgical intervention. And this is my reference. And thank you.
Okay, alright. So, any question for second presentation? Aiman, setelah itu you hantar mana email ya? Ke ini, on WhatsApp?
Ya, saya hantar saya email.
Email ya.
Slide.
Hantar hari apa? What day? Bila hantar?
Hantar hari Ahad, Sunday.
Sunday.
Hantar pagi, 8 pagi.
Tak masuk email betul ke? Send ya kan?
InsyaAllah betul.
Sebab my inbox tak ada.
Tak ada
Sunday. Oh, ni dia. Tak masuk inbox ni. Masuk ni. Alright, tak ada question ke ni? Senyap je semua ni.
I have a question.
Alright.
You mentioned muscular nodes is painful, but genuine lesion are painless. So do you think they can happen at the same time?
Genuine lesion is painless, but osseous nodes is painful. Yes? What is the question?
Do you think they can happen at the same time? Because you know how to differentiate between painful and painless.
Good question. Firstly, osseous nodes and genuine lesion occur at a different site. Genuine lesion,
different side tu macam mana?
as what I understand, which is not, I don't know my understanding is true or not, but genuine lesion occur at the palm, the sole, whereby osseous node occur at the, mostly we can observe at the tips.
On the mana yang genuine lesion?
Them at the tips. That's why I was asking.
I'm not sure.
Actually location tu no matter. Yang penting on the apa namanya distal extremities kan, ya on hujung-hujung jari ke, kat palm ke, sometimes kan plantar ke. The problem actually you need to explain, ada tak your file ni? The pathophysiology ada tak?
The pathophysiology of osseous nodes ni.
Ada tak ni? Tak ada ya?
Dalam slide ni tak ada.
Okay. Yang one is immunologic phenomenon, and then another one is inflammatory response. So yang painful tu ya sakit lah. Kalau you pegang sakit, even you tak pegang pun sakit. Yang apa osseous node yang sakit ya. Ada inflammation. Jadi akan sakit lah. Kalau gen ke terbalik. Yang sakit yang mana? Yang painful? Saya pun lupa dah.
Osseous.
Osseous node kan painful kan? Ya painful tu dia, karena dia apa? Sama lah kalau ada inflammation, dia ada punya bradykinin release, dia akan sakit lah, painful. Another one yang genuine lesion tu only immunologic phenomenon je, dia nampak ada lesion without pain lah, sebab tak ada bradykinin dia. Ada, you should baca di pathophysiology dia.
There's a question in the chat, Aiman.
Sorry? Question apa?
In the chat box.
Oh,
I read the question. I have question. Why the patient present with hematuria and proteinuria?
Okay. Aiman jawab. Hematuria, proteinuria. Patient IE. Aiman jawab. You tadi explain kat mana? Kat simptom ya? Kat investigation ni. Aiman mana? Boleh jawab tak?
Aiman, mute Aiman.
Mana Aiman?
Kalau berdasarkan kefahaman saya betul kot. Boleh kot. Tapi berdasarkan kefahaman saya tak tahu faham ke tak.
Jawab.
Saya cuba. Mungkin sebab deposition kat kot. When the neurological deposition, dia akan cause injury to to renal. And as we can see that glomerulonephritis is one of the main complication of IE. So bila glomerulonephritis, mungkin dia akan menyebabkan kidney injury, itu menyebabkan dia hematuria.
Okay, betul lah. If the infection to cause IE, sometimes ya also cause glomerulonephritis lah. Kalau ada glomerulonephritis, when you check the UFAM, ya akan nampak hematuria, proteinuria. If no glomerulonephritis, ya tak ada lah. UFAM akan clear. Agent, actually all ya possible lah. But usually yang glomerulonephritis kan 70% due to streptococcal kan. Kalau yang other agent jarang lah yang akan develop AGN. Alright. Okay, any more questions? IE ni sama lah ya. Penting this infection of the heart lah, ya endocard, dan as well as myocard and pericard pun kena juga actually ya. The causative agent tu ada banyak kan, yang head check and then staphylococcus and streptococcus lah. Dan yang penting tu how criteria of the diagnosis, because the features actually not specific ya. Bukan kalau IE pasti kena sakit dada dulu, chest pain dulu baru you diagnose IE. No ya. Usually chest pain pun tak selalu. The symptom will be only kita sebut inflammatory response je, SIRS je, systemic inflammatory response syndrome. Dia nampak tachycardia, tachypnea, and then maybe ada hypotension. So sama je, semua sakit sepsis pun sama ya. Septic punya features ya sama ya. So which infection yang cause IE, you need criteria of diagnosis ya. Because not all infection akan develop IE, and then not all sepsis akan develop IE. Ada certain infection, certain sepsis ya yang dia akan develop IE ya. So kriteria itu kita pakai Duke kriteria. Dia ada major, ada minor, ada clinical, ada apa nama? Saya tak hafal pula. Mana tadi? Kriteria. Ada culture, ada imaging, and then ada yang some minor kriteria. So kalau definitif, kalau dia 2 major or 1 major plus 3 minor or 5 minor yang clinical and with pathology. Possible kalau only 1 major and 1 minor or 3 minor. Bukan IE kalau less than 3 minor, yang major negatif semua ya. So pakai this criteria and then we can we can develop diagnosis of IE ya. So yang penting tu pathological and clinical criteria tu apa, you kena faham ya. Pathological tu you jumpa di pathogen ya. Can use the blood culture yang positive blood culture, tapi syarat dia ada ya, kena from two positive blood culture yang di apart more than 12 hour atau from 3 different site ya. So ambil 3 different site of blood culture semua positif sama ya. Tu atau ambil 2 kali. Sekali ambil and then next day atau another 12 hours baru ambil lagi ya. Itu yang penting ya. Culture kena positif, similar culture. And then yang imaging tu yang penting echo ya. There are usually vegetation, and then tadi usually ada valvular heart disease lah, ada mitral ke aortic regurg usually ya. Kalau clinically ada new murmur apa-apa. So you baca yang criteria of the diagnosis. Okay, satu itu. And then once you establish diagnosis of IE, so we start antibiotic. Yang penting itu because the antibiotic, the organism that cause IE itu usually very pathogen, pathogenic agents. So treatment dia tak cukup macam biasa. Biasa kan standar antibiotik treatment kan 5 hari dia selesai, sampai seminggu pun cukup, yang lama pun 2 minggu. IE dia kena lama ya, at least 6 weeks. Dia kena ada empirical antibiotik, ikut protokol 6 week antibiotik, 4 to 6 weeks lah. IV ya. So memang patient kena stay lama. Kalau you diagnose IE, different ya management with other patients. Kalau other patient maybe seminggu dah balik, sometimes 3 hari pun dah discharge. Kalau IE kena 4 minggu ke hospital, sometimes 6 weeks, sometimes more ya. So kena explain betul-betul because need IV antibiotic at least 4 to 6 weeks. Dan kalau dah keluar sensitivity itu, boleh juga kita tukar antibiotik lama lagi ya, depend ya. Kalau antibiotik kalau organisme dia multi resistant, lagi susah lagi nak treat. Kita bagi antibiotik apa-apa dia tak mati kumannya. So need need to explain well to the parents, to the patients. Itu yang penting IE. Then another one, ada risk kan, bukan semua orang akan develop IE, no. Macam kita yang normal people tu low risk lah. Jarang kalau kita demam, ada kena kuman, for example masuk kuman Staphylococcus, bukan otomatis develop IE, no. Very rare yang low risk. Ada yang high risk develop IE. We need to define which individu yang high risk develop IE. Kita kena tahu. Kena ada. Table ada tadi. Aiman, saya tak dengar sangat. Risk stratification of infective endocarditis.
Ada list.
Ada kan. Usually patient-patient with congenital or acquired heart disease yang kompleks lah. Kalau congenital yang kompleks, congenital heart disease yang cyanotic. And then kalau yang acquired itu yang post valvular replacement, kalau ada artificial valve itu dia high risk develop IE. So individu like this tu we need to protect them from IE. Kalau ada apa-apa procedures, we need to give antibiotic supaya tak kena IE ya. Kalau ada kuman supaya tak kena IE. Kalau low risk macam kita tak payah bagi antibiotik hari-hari ke kalau tak perlu ya. Alright. So itulah the concept of IE. Yang first tadi criteria of diagnosis. You kena tahu patologik, major, minor criteria, clinical criteria apa je. Tadi from the findings ya. Macam Generalization Osler note actually rare in children. You jarang jumpa children with IE, only 1 or 2 cases yang you akan jumpa this findings tu. Most likely we establish diagnosis of IE itu based on the fever, patient fever, and then blood culture positive, and then masa buat echo ada vegetation or valvular heart problem dia mitral or aortic regurg. Baru kita diagnose yang macam channelization, Osler note, rod spot, fenomen macam ni rare actually in children ya. Yang penting tadi criteria of diagnosis, and then how to treat, and then how to prevent ya. Yang penting tadi high risk IE, you need to recognize high risk individu yang high risk IE, we need to give antibiotic prophylaxis following procedures ya. Alright, so clear ya. Nanti you can share the slides to audience boleh baca lagi the slides. And then you learn from pitch protocol, from references ya. Ada pitch cardiology textbook. Nelson pun boleh ya. Alright. Okay. Any more question? Alright. So proceed with third presentation. Yeah.
Assalamualaikum.
Waalaikumsalam.
Can you hear me?
Yes.
Can you see my slide? Okay. Okay. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah Rabbil Alamin wa afdalus salati wa atammu taslim Sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. Okay, my name is Muhammad Akmal bin Muhammad Hisham, metric number 1817435. And today I will be presenting about heart failure in childhood. Okay, as you can see over there, I put 3 hearts. So you choose which heart you want, whether it is qalbun salim or qalbun marib. Okay, so this will be my outline for my presentation. So we'll be beginning from the definition, and then I will explain about the physiology and the etiology. Then I proceed with pathophysiology, the clinical manifestation, physical examination, investigation, management, and prognosis. So over there, I put a big red heart for you as a reminder that we should take care of our spiritual heart, because that is the place of Allah's evaluation on us. Okay, so what is meant by heart failure in childhood? Heart failure itself, what is meant by heart failure? So according to my references, heart failure is meant by a clinical syndrome when there is insufficient of cardiac output to meet the body metabolic demand, and it is characterized by respiratory distress, growth failure, venous congestion, and exercise intolerance. Okay. And for your information, if you understand my previous colleagues' presentation just now, seminar just now, inshallah you will understand this, because heart failure is the result of both previous presentation just now. Okay, so when we are talking about cardiac output, it is a must for us to remember a very important formula that we learned in preclinical, which is the cardiac output is equal to heart rate times stroke volume. I put 3 times to emphasize on the importance of this formula. Only if you understand this formula, inshallah, you will understand the physiology and you will understand the pathophysiology of why heart failure can occur, especially in childhood. Okay, now in physiology. So with regards to the physiology of this, of the physiology of the heart, we need to understand first how the cardiac output function. And 2 factors that affect the cardiac output is heart rate and stroke volume. However, the stroke volume and the heart rate doesn't just happen by itself. It must have some sort of other factor that could affect them. For example, in heart rate, it is affected by autonomic innervation. It is affected by hormones and even atrial reflex. And stroke volume, okay. Before that, let me explain to you. Stroke volume is meant by end diastolic volume minus end systolic volume, and heart rate is meant by amount of the number of beats, that the number of heartbeat in a minute. Okay, for the stroke volume, it is affected by preload, contractility, and afterload. So these 3 factors, anything that affect these 3 factors can cause heart failure. Okay, and these 3 factors is affected by another 5 factors. What are they? They are venous return, filling time, autonomic innervation, hormones, vasodilation, or vasoconstriction. So anything wrong with this factor could bring arise to heart failure. Okay, before I proceed to the pathophysiology, let me show you the etiology that can cause heart failure in childhood. Yeah. Okay. So as you can see in the table, I've divided them into their age group, starting from fetus, premature neonate, full-term neonate, infant and toddler, and child until adolescent. Okay, for information, different age group have different causes, different etiology that can cause heart failure. But what you need to emphasize is that the most important etiology, the most important cause that can give rise to heart failure in childhood is congenital structure anomaly. It can be ventricular septal defect. It can be tetralogy of Fallot. It can be PDA, patent ductus atrocis, and other more. This is the most common. While for the older children, for the child and adolescent, the most common cause that give rise to heart failure is acquired valvular disease, such as we can see just now, Aiman explained about infective endocarditis, okay? And primary myocardial disease, such as cardiomyopathy. Okay, now let me explain to you about the pathophysiology, why the heart failure can arise. Now, as I mentioned just now, according to the formula, cardiac output is equal to heart rate times stroke volume. So heart rate and stroke volume. So heart failure arise from these two formula, these two factor, whether it is heart rate, factor that affecting the heart rate, or the factor that affecting the stroke volume. And the two factor are grouped into another two, which is the ventricular dysfunction, whether it is a ventricular dysfunction or abnormal loading. Okay, for the ventricular dysfunction, it could be systolic dysfunction and it could be diastolic dysfunction. So when a patient has a systolic dysfunction, that patient might have a reduce in their ventricular contractility. So let it make a logic, okay, a logic sequel. So when there is less contractility of the heart or the ventricle, what will happen to the blood? The blood will not be distributed throughout the body properly. Okay, while in diastolic ventricular dysfunction, if this patient is having this diastolic dysfunction, patient might have decrease in ventricular compliance. Means that the ventricle cannot accommodate the volume of blood that is entering into it. Okay, and these two conditions might be caused by cardiomyopathy, might be caused by myocarditis, might be caused by myocardial infarction in adults, and even arrhythmia. Okay, for the abdominal loading, when we are talking about loading, there is two kind of loading that we should put in our mind, which is the preload and the afterload. Okay, for the preload, what affect the preload? A condition that could affect the preload is, as I mentioned, as I put there, is the left to right shunt. What is meant by that? Left to right shunt is meant, okay, it is meant by blood that should be on the left chamber shunt into the right chamber. So when blood that should be on the left, that should be in the left chamber, move to right chamber, what will happen to right chamber? Right chamber will be overload, right? And this condition is contributed by atrial septal defect, ventricular septal defect, and even patent ductus atrocis. And the next reason that can cause that effect, the preload, is the valvular insufficiency. It can be aortic regurgitation, like Suhaib mentioned just now, explained just now, mitral regurgitation. These two conditions will subsequently cause volume overload. Okay, for the afterload, what affect the afterload? It is the ventricular outflow obstruction. Like Suhaib also mentioned, the aortic stenosis and the pulmonary stenosis. Okay, let me give you an analogy about the afterload. Okay, let's say that you have a bottle, one inlet and one outlet. Okay, now the outlet is being blocked and being narrowed. And then you start filling the bottle with water from the inlet. You keep filling. What will happen to the pressure in the chamber, to the heart? The pressure will increase, right? And if it is not compensated because the outlet is being narrowed and being blocked. So subsequently and slowly, that it will develop a pressure overload. And all of this condition contributed to the diminish in cardiac output, causing insufficiency, causing in hyperperfusion throughout the body. Okay, now the clinical manifestation, I will explain this one by one. Why there is such clinical manifestation? So I divided into infant and older children. So in infant, that infant will present with respiratory distress, will present with tachypnea. in your opinion, why the infant have such clinical manifestation? Why they manifest like that? It is because we know that when there is hypoperfusion, throughout the body, the metabolic demand will increase. Okay, right? The metabolic demand will increase, causing the heart to become overworked. And as the heart become overworked, we know that respiratory system and the cardiac system is interrelated to each other. So the more the body need, the more the metabolic demand, the more the child will breathe. And it will subsequently lead to tachypnea, respiratory distress, and grunting, poor feeding, diaphoresis feeding, berpeluh, sweating. Okay, while in older children, the same reason why. So the children will appear with dyspnea and orthopnea because of the heart trying to compensate the fluid. The blood cannot return to the heart properly, and when the heart is not pumping well, blood is not distributed throughout the body properly. So the children will appear easily fatigued, but slowly to recover from the fatigue, become intolerant to exercise, and moreover can develop edema. Why edema? Because there's fluid retention in the lower limb, especially lower limb. Not only lower limb, can be in the liver, hepatosplenomegaly, because the fluid, the blood cannot return. The blood is not returned back to the heart properly, and the heart cannot pump the blood throughout the body properly. Okay, and present with wheezing, palpitation, and recurrent vomiting. Okay, for the recurrent vomiting, it only mentioned in the book, but I am so sorry because I cannot find the clear explanation about why patient presented with recurrent vomiting. So I'm so sorry again. Okay, on physical examination, okay, what you will find in the patient with heart failure? First, for sure, you will find the patient will having tachycardia. Why tachycardia? The same thing, because your heart is trying to compensate. The heart is not pumping well, but it tries to compensate the metabolic demand of the body. So it needs to pump blood throughout the body. So there might be tachycardia, and there might be also poor peripheral pulses because the affection of the cardiac output just now, right? And poor peripheral perfusion. So these three is linked together normally. Okay, on cardiac finding, what you will find out is this patient might have hyperactive precordium. I will show the picture afterwards. Precordial bulge, gallop rhythm, systolic murmur. Okay, and on pulmonary finding, what you will see in this patient, when you check this patient might have resting tachypnea. What is meant by resting tachypnea? Okay, tachypnea, increase in breathing rate during resting, right? Okay, and when having this kind, we know that I've explained just now why this patient is having tachypnea. So I think I don't need to explain again. And this patient might also have subcostal recession. In Malay we call it as celahan. So at the chest you can see sort of groove on the chest. I will show other picture afterwards. And lung crackle may be audible. Why lung crackle may be audible? So as you can see just now, blood from the lung, okay, oxygenated blood from the lung cannot return to the heart properly because of the insufficiency in the heart, the cardiac output, right? When the heart is not pumping properly. So there is pooling of blood and fluid in the lung. The same goes to the systemic finding where you find out the hepatosplenomegaly and edema. The same reason why there is such condition, hepatosplenomegaly and edema. Okay, so this is okay, this is the precordial bulge. You can see that there is bulging on the chest of this children, right? On this child. And this is subcostal recession. We have two, intercostal recession and subcostal recession. But for the heart failure, according to my resources, my references mention that patient predominantly presented with subcostal recession over here. You can see that there is sort of groove over here on the chest of this patient. Okay. And next, okay, we proceed with the investigation. How we want to check whether this patient is having heart failure or not. So first and foremost, we do chest radiograph, chest X-ray. Why? To check the size of the heart, the pulmonary vascularity, the contours of the heart. For the this patient, if you are doing chest X-ray, we might expect the child having cardiomegaly. Why? Because as a compensatory mechanism, the heart have to work harder. So because of that, the size of heart will increase because of the compensatory mechanism itself to accommodate the body metabolic demand throughout the body. And on ECG, we do ECG also. Why? To evaluate any rhythm disorder. So normally patient with cardiac failure will present with sinus tachycardia. I will show the ECG afterwards in the next slide. Okay, echocardiography. Echocardiography, the same reason is as what Aiman mentioned just now, not only to check the presence of the vegetation, but also in this patient, in heart failure patient, if you can do echocardiography in a heart failure patient, you can evaluate the size of the heart, the size of the chamber, the ventricle size, the atrium size, the structure, whether it is functioning properly or not, and the function of the heart. Okay, and you can see also the valve, whether it is functioning properly or not. Okay, and next, the cardiac CT scan and cardiac MRI. Okay, so for the cardiac CT scan MRI, mainly used for management, for surgical planning. Okay, so it provide much information, provide a very detailed information. Okay, what to do with this patient during the surgery. Okay. Okay, this is the sinus tachycardia. Okay, this is the actual radiograph of a child having heart failure. You can see, right, the heart, there's cardiomegaly. Okay, the enlargement of the heart due to the compensatory mechanism to accommodate the body metabolic demand. Okay, to pump blood throughout the body. Okay, for the lab test, so we do complete blood count, and we are looking for anemia. Okay, so what type of anemia that we suspect in this patient? So in this patient, in heart failure patient mainly, we suspect that this patient might have IDA, iron deficiency anemia. And then we also make a marker, cardiac marker, which is the troponin, INT, because when we know that if the heart is injured, it will release sort of markers and to indicate that there is some injury to the heart, and that marker is troponin I and T. Okay, so next we also make renal profile, and in severe heart failure, patient may present with hyponatremia, and other function of why we make renal function on this patient, we investigate them laboratory test with renal function. Renal profile is that we use it to determine the baseline electrolyte to start the therapy. And also the liver function test, the ALT, the AST. Why? Because if patient is having right-sided heart failure, that patient may have injury to the heart. And injury to the heart can release the marker, right? The marker AST, ALT, the enzyme, liver enzyme. So this liver enzyme, elevation in liver enzyme, indicate that there is something wrong with the heart. There's something wrong in the heart. Okay, so it could give a clue for the physician to check whether this whether it affect the heart, whether the etiology come from where. Okay, so next, the management. So for the goals of our management is we are trying to improve the sign and symptom and to reduce morbidity and mortality, and lastly to correct the underlying problem, which is the etiology. So if you if you are able to point out the etiology and you correct the etiology, inshallah, the heart failure will resolve. Okay. And for general measure to start the treatment is that by bed resting, okay, to reduce the body metabolic demand. Don't exercise too much. Don't do vigorous activity. Just rest at the bed. Okay, children. Even though we know children are very playful, right? Give them oxygen supply, okay, and fluid and salt restriction for adult children, and for infant. Just now the infant may present with poor feeding. So if there is poor feeding, what we need to do is that we need to optimize the feeding regimen so that the nutritional status will improve. Okay, for the medical therapy, the drugs that we use is hypertensive drug. The same drug that we use in infective endocarditis just now, right? To prevent the heart failure. So we use furosemide, spironolactone, captopril, and digoxin. And the definitive therapy, the best way to cure everything, okay, without any best way to cure the heart failure is by surgical and transcatheter treatment, okay. And we may also use pacemaker implantation, and finally the heart transplantation. This is the best way. But yeah, heart transplantation very expensive. Okay, so for the prognosis, normally in children, the heart failure, the outcome will be better compared to adults. Okay, because most of the time, like I mentioned just now, the most common cause is structural defect, right? Structural heart disease. And that structural heart disease is easily reversible by therapy. However, in children with cardiomyopathy, the outcome, the prognosis will be poor. Okay, because there is around only 50% of chance of that children to live for the next 5 years. Okay, especially with dilated cardiomyopathy. So yeah, cardiomyopathy in this patient normally it gives good outcome, but in cardiomyopathy not so good outcome. Maybe the children cannot live beyond 5 years, the next 5 years. Okay, that's all from me. This is my references. And thank you. Any questions?
I have a question.
Yes.
Yeah.
So I remembered Dr. Taufiq mentioned how to differentiate for a cardiovascular disease. We should differentiate between congenital, acquired, cyanotic, and acyanotic. So it's where does heart failure categorize under? Like, does it go under cyanotic? Does it go under?
Oh, okay. Thank you very much. According to my reading, my references, heart failure heart failure is the outcome of all of them. Okay, and whether it is cyanotic or not, it depends. It can be both. It can be cyanotic. Patient may have heart failure and at the same time cyanotic, and at the same time it's not cyanotic. It depends on the underlying etiology. For example, the patient is having tetralogy of Fallot. You know, right? Tetralogy of Fallot. I think some of our colleagues will present that next week. Okay, for the tetralogy of Fallot, the patient, yes, at the same time is having heart failure and he is cyanotic. So it depends on the underlying etiology. For infective endocarditis, the underlying etiology of heart failure, if the patient might not cyanotic, pink, but there is heart failure, right? So it depends on the underlying etiology. Okay.
All right. So all heart disease can develop heart failure. Okay. Tapi some correction ya. There are certain heart disease that rarely bukan akan commonly develop heart failure, can rarely develop heart failure. So which are they? So you need to know the structural defect. Usually, if there is what we call it right ventricular outflow tract obstruction, macam stenosis tuh, tadi macam pulmonary stenosis, atau yang LVOT obstruction macam aortic stenosis. The problem tuh yang the initial problem should not necessarily heart failure. So contoh ya, kalau ada RVOT obstruction, ada pulmonary stenosis with TOF ya, pasien-pasien TOF itu dia ada pulmonary stenosis kan, cyanotic heart disease, dia TOF, right ventricle outflow dia obstructed, ada pulmonary stenosis. So dia the problem mainly is not due to heart failure. The problem will more on the hypercyanotic spell. Dia akan develop TED spell, dia akan develop severe cyanosis yang sampai hypoxia. dia akan jarang dia akan develop heart failure itu later lah, lambat lagi nak develop heart failure. Yang usually the common main problem tuh atau terlalu di TOF itu dia akan third spare or hypersynotic spare. Kenapa dia lambat di heart failure? Ya, karena tadi obstructed ya. The flow to the pulmonary dia kurang, so that's why dia the congestion to the pulmonary circulation tuh sikit je. Bukan sikit, memang not congested kan. Dia akan kita sebut oligemic lung. Pulmonary circulation dia kurang sikit. So dia patient will not develop tachypnea, bilateral collapse tidak akan develop lah. Bukan tak akan jarang lah, susah. Alright. Another problem tadi kalau yang aortic stenosis, dia left ventricular outflow tract obstruction. So dia flow to the systemic dia kurang kan. So problem main problem dia bukan heart failure tapi karena inadequate systemic circulation dia akan jadi macam kalau to the brain circulation, inadequate brain circulation dia akan jadi syncopal attack. If dia inadequate coronary artery vascularization dia akan develop heart attack, angina ke, infark myocard ke, macam tu ya. So you need to understand the pathophysiology first. Memang all possible, tapi ada certain defect, problem that dia akan rare lah, akan the main or early problem bukan heart failure but other problems ya. Tapi kalau the problem macam VSD, ESD itu due to the excessive flow to the right heart, dia kan left to right shunt kan. Right ventricle dia banyak flow, dia akan masuk pulmonary, dia jadi congested, heart failure. And then yang systemic return pun from vena cava dia akan congested jadi heart failure. Cerita macam tu ya. So you need to understand the hemodynamic, so why the heart failure develop. So memang all possible tapi tengok di defect lah. Ada yang akan cepat develop heart failure, ada akan lambat lah. Yang lambat ni problem dia yang lain lah, bukan heart failure dulu. Other problem usually comes first. Okay. So, any other questions? Dah tak ada? Dah penat? Yes?
There's a question in the chat box.
Oh, chat box. Amni. Regarding the investigation, why does the patient will have IDA which is hypochromic microcytic anemia? Ini tanya pasal IDA pula. Ada ke tadi? Akmal nak jawab sekarang ke nak tunggu hematologik punya seminar? Ada nanti masa hematoseminar tu one of the presenter should present about the IDA kan.
I think I tried to explain a little bit, but I'm not very sure about my answer. I'm very sorry, Amni, if I cannot give you clear explanation about this. So according to my reading on a few textbook, mentioned that this patient with heart failure might present with iron deficiency anemia is because of there is sort kind of pool sequestration. The term is pool sequestration, but I'm not sure what is meant by the pool sequestration over here, where it has been sequestrated. So that is the point where the inclarity of my answer. I'm very sorry.
Coba tengokkan slide ni. Ya, saya pun mana tadi? Saya tutup pun. Investigation ya?
Ya, saya doktor. Investigation.
Okay. Mana tak ada pun kat sini.
Oh, look for anemia. I just explain it verbally.
Oh, verbally. Kalau direct relation to IDA, actually kan IDA kan it is nutritional anemia ya. it is any case of inadequate iron punya intake, kalau kurang zat besi ya dia IDA ya kan. Yang direct effect from the heart disease actually not really direct effect, usually indirect lah. Maybe patient with heart disease if develop heart failure ke any other problem dia akan jadi less intake. One answer ya. The second answer ya some possible problem with heart failure, but the blood will be diluted kan. Kalau diluted maybe relatively will develop anemia. Tapi it is not direct cause that heart disease will cause IDA, no. Usually it is other concurrent concomitant issue ya. Mainly kalau IDA ya problem with inadequate iron intake ya, nutritional anemia. Kena you ask why hypochromic microcytic kalau hypochromic microcytic ya this simple lah, due to inadequate iron ya, the erythrocyte will be hypochromic microcytic. Nanti picture presenter masa hematologi seminar should be there lah. Siapa yang present hemato seminar nih? Tak mengaku. Udah ada present kan belum?
Belum lagi dok.
Belum. Hemato next week juga ya? Hemato. Nih Fatin Hanani mana? Jumpa dah. Mana Fatin Hanani? Tak keluar. Mana? Dah buat slide ke belum? Dah baca ke belum Fatin?
I've done my research, a little bit research about it.
Okay. Nak present nanti next week ke nak present sekarang? nak explain sekarang? Ada yang tanya pasal IDA hypochromic microcytic ni.
Maybe later.
Okay, alright.
Because I'm not quite
nanti
sure
next week you tanya balik ke Fatin tu ya. Alright. Okay, any other questions?
Doctor, for
Yes.
the anemia, right? Can
Yes.
it be due to when the patient has heart failure? So that means there will be reduced in renal perfusion, renal blood flow. So when the kidney is not in a good condition, I mean lacking in blood flow, so the kidney cannot produce erythropoietin, right? So that will impair the bone marrow to produce blood cells. That may lead to anemia. Could it be like that?
This another possible pathophysiology-nya. Tapi for certain nanti you baca di textbooknya, you read the textbook. Is it common this connection, this mechanism or no? Yeah. Because logically yes, kan. Inadequate blood flow can reduce the EPO production, but is it true like that? Ya, we need evidence lah. Sometimes logical thinking itu memang without evidence kan. So evidence-nya ya nanti you read the textbook pathophysiology. Is there memang direct or indirect correlation between inadequate perfusion to reduce erythropoietin production. Okay.
Okay. Thank you, Doctor.
Alright. Okay, any more questions? Maybe a little bit summary for the third ya. Heart failure ini memang very important to understand ya, because so many heart disease will have complication of heart failure kan. We need to understand the pathophysiology well ya, why heart failure develop. So again, yes, similar explanation ya. You need to understand the hemodynamic. So simple understanding about the heart failure, you just classify, or bukan classify, you just need to recognize left heart failure and right heart failure. Ya. Kalau left heart failure means failure of left heart, left ventricle to pump the blood. Ya. Maknanya if the left ventricle fail to pump, congestion will happen on the pulmonary vein, on the pulmonary circulation. So the symptom will be pulmonary symptom lah. Patient will develop tachypnea, bibasal cramps. Kalau severe dia develop pulmonary edema juga ya, acute lung edema. Whereas kalau dia right heart failure, fail of the right ventricle to pump, maknanya blood will be congested to enter the right heart kan, to enter the right atrium and ventricle. So will be congested on the vena cava, IVC and SVC. So the symptom, you will get a symptom of IVC congestion, hepatomegaly and leg edema. Kalau SVC congestion, you will have increased JVP. Before this congestion tuh left heart ke right heart kan, it will be fail compensatory mechanism. Tadi before congested kan, heart will try to increase the capacity kan, dia akan hypertrophy, akan dilated. So it is common, almost all of heart failure you will see a cardiomegaly, except in one condition. One condition that patient can develop heart failure without cardiomegaly. In case of total anomaly of pulmonary vein drainage, TAPVD. So pulmonary vein tuh from the lung normally will send blood to left atrium kan. TAPVD ini vein pulmonary vein itu tak masuk ke left atrium tapi masuk tempat lain. Commonly dia masuk right atrium. Ada yang suprakardiak dia masuk ke superior vena cava, SVC, atau yang infrakardiak dia pulmonary vein masuk di IVC. So dia akan pulmonary vein will send back the blood to the right atrium, to the right heart. So akan easily develop right heart congestion kan. So akan bertumpuk, akan bertembung blood from pulmonary vein, SVC, IVC itu akan berebut masuk right atrium. Easily develop right heart congestion, akan develop right heart failure without even cardiomegaly. Kalau yang lain other heart disease usually akan develop cardiomegaly first to increase pumping tuh hypertrophy, dilated ke depend ya. Kalau dia pressure low dia akan hypertrophy, kalau dia volume low dia akan dilated ya. So, kalau udah after dilated or hypertrophy dia akan fail kan. Kalau udah fail barulah congested, barulah akan develop symptom of heart failure. Itu yang simple explanation ya. And then other usually other common mistake ya, not all heart failure will have pulmonary hypertension ya. Pulmonary hypertension is another complication of heart disease, tapi dia usually rare lah. In certain heart disease dia akan develop pulmonary hypertension. Usually develop failure first. Memang kalau dia congested of left heart, pulmonary circulation congested, sometimes lama-lama dia akan increase pressure juga, pulmonary hypertension. Itu adalah next step, usually next step of the complication. After heart failure baru develop pulmonary hypertension. Tapi ada certain situation juga dia tak nampak sang heart failure, tiba-tiba directly develop pulmonary hypertension. Ya, depend on the structure of the structure of the heart defect. Usually rare lah yang pulmonary hypertension, memang ada case ya, bukan rare sangat ya, common ya, tapi the most common of the complication of heart disease should be heart failure. Yeah. Okay, alright. So hopefully no more question ya. Dah pening semua. Nanti you baca balik ya. The purpose of the seminar is not to make you understand all the problems ya. At least it is a trigger ya. After this kalau you tak paham tu, it is better ya. If you not understand, it will be better you have an eager ada keinginan untuk baca ya. So baca ya. Jangan you tak paham you terus pening kepala tidur ke main game. Kalau udah pening kepala tu, it should trigger you to read lah. After this you go to tak boleh pergi library dulu ya, masih kat rumah. Ya, you open your search engine tu, Google ke apa-apa, read ya, baca. Kalau ada textbook kat rumah ya baca ya. Alright. Okay. Alright, with that we close our session today with Taufiq and Nasr. Subhanallah. Alright, thank you all. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Doctor.
Thank you, Doctor.
Thank you, presenter.
Thank you, Doctor.